Well, good afternoon, everyone. We've got just a few more people joining, so we'll just give this a couple of seconds for that to clear, and then we will get fired up. I think what we'll do is we'll just keep admitting them as they show up, but let's go ahead and get started. So my name is Norm Thurston. I am the Executive Director here at NADO, the National Association of Health Data Organizations. And this is our March edition of the NADO Hot Topics webinar series that we do every other month or so on whatever topic is of kind of present interest. And today's topic is going to be the RAND Hospital Price Transparency Study. And we'll introduce that in just a second. But before we do that, I want to recognize our 2023 NADO event sponsors. So these are organizations that sponsor NADO events throughout the year. And particularly want to recognize our Terabyte sponsors, Milliman, and our brand new collaborating partner, Mathematica, along with our Gigabyte sponsors, Barry Dunn, Comagine Health, Friedman Healthcare, HSRI Medicasoft, and OnPoint Health Data. And we really do appreciate them and the great things that they do to help us to serve our members and our audience better. So with that, I'm going to turn the time over to Joe Porter, who will introduce today's speaker and presentation. Joe, go ahead.
Thank you. Thanks, everybody, and good afternoon or good morning, depending on where you're calling in from. I'm pleased to welcome Chris Whaley to our call today. Chris is a health economist and professor at the RAND Graduate School. Chris is going to talk to us about the RAND Hospital Transparency Study, which many of you may just hear referred to as the RAND study. And I was joking with Chris earlier that it seems like people believe this is the only RAND study there is because it's just referred to as the RAND study. But it has got a lot of traction in its 4 iterations at this point, Chris, and you're working on the 5th, if that's right. And many of you may have seen the work of the RAND study incorporated into a tool called Sage Transparency, which allows for some really interesting visualizations of the data. So Chris is going to talk to us a little bit about the RAND study and the work that's done on that, some of the anticipated future work that's happening in the most current iteration. And one of the reasons that we wanted to bring this all to you as an audience is because there's an opportunity for additional states and additional data to be incorporated into the RAND work, which Chris will talk about. So as I understand it, and Chris will correct me if I'm wrong, now is a good time for you all to be letting the folks at RAND know that you might want to have your states represented in the data through the collaboration. So we wanted to give you all an opportunity to hear more about what is currently happening, what the future work could look like, and how you might get involved. So with that, I'm going to hand the floor over to Chris and let him talk to you about all the super cool stuff that's going on in the RAND study.
Chris, you might be on mute.
Still on mute.
Great. Well, thanks for having me, and thank you, Joe, for the introduction. Just quick housekeeping. Can you see my slides? It shows I'm sharing, but let me know if you cannot. And just another point of housekeeping, that the study was funded by the Robert Wood Johnson Foundation, and then also several participating employers and organizations. And so, as Joe said, really excited to present some of our work on looking at hospital prices. We focus in this study mainly on the population with employer-sponsored insurance or other forms of commercial insurance. And the reason is just that employers in the United States play a really critical role in financing the healthcare system. So collectively, employers spend about $1.2 trillion on hospital costs, or healthcare costs rather, with the largest chunk of the pie, just under $500 billion going towards hospital care. And employers also play a really important role in providing coverage and are actually the source of coverage for the largest chunk of people in the country, and provide insurance for about 160 million people. This is a market that, while very huge and important, has also faced many challenges, particularly around affordability. And so if we just look at the last decade, where that $1.2 trillion comes from and how it's financed, we've seen a huge increase in deductibles. So now it's not uncommon for many plans to have $5,000 or more deductibles. I think on many of the health insurance exchanges, plans have 10,000 or more deductibles. And so this is a huge burden in cost sharing for patients. Premiums have increased by about 50% or over 50%. I think now that the national average to provide a family premium for employers is around $22,000 or $23,000 per year. And so that's a huge check that comes directly out of wages and other types of benefits. Inflation has increased by 25%. And of course, in the last several years, that's actually increased quite a bit more, and worker earnings are actually increasing less than inflation. So while employers are really important for financing the healthcare system, due to how kind of organization of healthcare markets in the United States and how much healthcare costs, we've collectively decided to pay for local pay increases in terms of healthcare dollars and not in terms of take-home pay dollars. It's also really important to think about what's the employer's role in providing benefits. And so how employers provide health insurance is they provide coverage to the workforce as a benefit, and in doing so, take money that would have gone to other benefits, as I said earlier, most notably pay, and use that to pay for healthcare. And in doing that, employers have both what I think is a strong moral obligation, and the Department of Labor codifies this as a legal obligation to be a strong fiduciary and make sure that they're using those dollars wisely and efficiently. And then the Department of Labor has a requirement here that employers can only use health plan dollars to act solely in the interest of plan participants and beneficiaries, and with the exclusive purpose of providing benefits to them. And so that's a pretty stringent requirement. But what's been, I think, really instructive to us as researchers in working with employers, and I think a huge source of frustration for employers and other purchasers, is that while they have this strong obligation to use dollars efficiently, healthcare for many employers is a black box where they write a check every month and really have no insight into what goes on behind the scenes, and in particular, prices that are negotiated on their behalf. And so what we wanted to do is take information mainly from employers, but also, as I'll highlight in a couple slides, from state all-payer claims databases, and give information back to employers on prices that are being negotiated on their behalf. And just to be clear, as researchers, I don't know what the right price is for healthcare, but that's really something that I think employers who provide benefits and also state policy regulators who are responsible for overseeing markets, and I think really know the markets and populations best, can determine whether or not a price is too high or too low. But in order to make that determination, there needs to be transparency around prices. And so what we want to do in this study is collect lots of data and try and provide transparency around prices for hospital care throughout the United States. So how do we do this? So we're currently on our round 5 study. So the results I'm going to present today are actually from our round 4 study. But the basic process is we start by obtaining medical claims data, mainly from self-funded employers. And so when we started this study in round 1, we just had a handful of employers from the state of Indiana. Then in round 2, we were able to expand to a 25 sample state or 25 state sample across the country. And then in rounds 3 and 4, we've actually been able to include employers from across the country. Some of the employers that we have in the data are relatively small employers. So think a manufacturing company that's in a particular geography, or say local school district that may not have too big of a footprint, all the way up to some of the largest companies in the United States who provide benefits for millions of individuals. We supplement that data with data from all-payer claims databases. In our first round, we actually did not have any APCD data. In round 2, we were able to add in 2 APCDs, so New Hampshire, which Joe's pretty instrumental in creating, and as well as Colorado. And then we were able to expand that in round 3 and 4 or rather 3 to 6 APCs. In round 4, we were actually able to get 11 state all-payer claims databases into our study. An advantage of having data from an APCD is that, as I'm sure many people are on the call are aware, and as the name applies, rather than just getting a kind of slice of data from an individual employer who knows how representative that data is, we can actually get a huge chunk of data for an individual state and really have lots of insight into that state. Now, I will note that 11 states is not the full number of states that have an APCD. There are some states that do have an APCD, but have restrictions around actually naming individual provider prices using data from the APCD. And so we limited our sample to the 11 states that actually had an APCD where we could use that data and say this is the price for hospital care at a given provider. And then in some cases, we're actually able to supplement that data with book of business data from a handful of health plans. With this data, we essentially aggregate and create a large database that pools everyone together. And then we think about measuring hospital prices in 2 different ways. So the first, and I think the one that gets the most traction, is relative to a Medicare benchmark. And so we're essentially saying, how much are our employers and other private insurers paying for hospital care relative to what Medicare would have paid for the exact same service at the exact same hospital and on the exact same day. And so this is a pretty, I think, interpretable way to think about variation in prices. So if we see that one hospital is, say, 200% of Medicare and another hospital is 300% of Medicare, we pretty quickly know which hospital is more expensive. Another advantage of the percent of Medicare measure is that it includes a lot of the kind of additional payments that Medicare makes, largely to make payments more reflect the cost of providing care. So for example, Medicare pays more for services that are done in high cost of living areas where, say, it costs more to hire doctors and nurses than in other areas where labor costs are a little bit lower. The second measure of price that we use is what we call standardized price. And so this is essentially a case mix adjusted average price that, instead of doing a percent of Medicare, essentially is a dollar amount after adjusting for differences in procedural complexity and patient mix. And so an advantage of this price is that it actually strips away a lot of the additional payments that Medicare makes, mainly, or at least the one that makes the biggest difference, is payments towards academic medical centers that receive a higher payment for Medicare. And so a given dollar at an academic medical center as a percent of Medicare will go less far than at a non-academic medical center or teaching hospital. And so with these 2 prices or ways of measuring prices, we have 2 ways of sharing results. And so the first way is actually to create a public hospital report. And so this is actually on the RAND website. You can go through and read our high-level findings and look at the kind of discussion of what this means for policy and for employers. We also have data where we have an Excel file where you can actually look at prices for individual hospitals and healthcare systems. And in addition to reporting prices on these 2 different ways, we also look at prices for inpatient and outpatient procedures. And another way that we've actually been able to make this data a little bit more user-friendly is through the Sage Transparency tool, which I'll go over in a couple slides. And if you're an employer, maybe it's great that we've got all this data that pools across the country, but maybe to make benefit design decisions for your own population, you want to know what prices look like for your own population. And so there we actually have an option for individual employers to say, I want to just kind of subset onto my own data and look at price variations within my own population. And as was mentioned, we're in our kind of next iteration of the study and actually in the process for planning for round 5. And so where we are right now is we've been spending the last couple of months signing data use agreements with both health plans, APCDs, and individual employers. And then are just now starting to get the first wave of data. So actually our first cuts of data for our next round of the study actually came in late last week. And we're following roughly the same process of collecting data, pooling it together, and then creating both the public tool through the RAND website and then adding to the Sage Transparency tool. and then also creating a private report for individual purchasers and employers. If this is something that is of interest, again, if you're a health plan, a state, or an all-payer claim, or an employer, the right process is really just to send me an email, and happy to share that at the end of the talk, and just say, I want to participate, and we've got lots of DUA language, and I've worked with many of the large health plans, and so really can get that ball moving pretty quickly. And we've got things at least kind of as hope is, we perceive can streamline the process. But one thing to note is our previous study collected data from 2018 through 2020, and the next iteration of the study will go from 2020, 21, and 2022. And so what did we find? So this is our high-level summary of average prices across each of the states that we looked at. And so this reports our primary metric of percent of Medicare for hospital prices for what commercial payers pay. And so in this table, or this figure, we see that prices for hospital care on average range from about 150% in states like Hawaii, Arkansas, and Washington, all the way up to over 300% of Medicare in states like Florida, West Virginia, and South Carolina. And so keep in mind that this is a very regulated industry, and a industry where there's lots of inputs into how providers are organized, and it's also a huge and important industry. But just across states, we find almost 2x variation in prices. And so I think as economists, this is always a little bit surprising. Healthcare markets in Seattle work perfectly fine, and people are still able to get access to high quality care. And so it's a bit of a question of why prices are half the price in Seattle, or in the state of Washington, as they are in states like Florida and West Virginia, South Carolina. Another thing to note is that while this shows just prices on average just across the states, if we were to look within a given state, we'd probably find just the same level of variation in prices just within that state, or even more localized metropolitan areas. When we look at what drives this variation in prices, we really find a minimal relationship between provider price and provider quality. We find no relationship between provider price and the share of patients that are covered by Medicare, Medicaid, or uninsured. And so that's the kind of common cost shift hypothesis, that providers have to charge higher prices to offset underpayments from public providers to patients without insurance. And we don't really find a lot of evidence, or any evidence rather, to support that argument. Where we do find a pretty strong relationship between provider price and other factors is with market share. And so providers that have a more dominant negotiation position and have a larger market share in the region are the ones that are able to negotiate higher prices with insurers. And so when we look across the country, that's really a strong factor that drives prices. Another thing we did is we looked at the components of hospital prices. So when you go to the hospital, you get a bill for what's called the facility fee. So this accounts for the services that the hospital provides. So whether this is, if you need a joint replacement, that device cost, the cost for the hospital bed, and the overhead cost to run the hospital. And typically for your hospital bill, rather, that counts for about 85% of the hospital bill. And the other component, the professional fee, which goes towards physicians and healthcare providers, accounts for about 15%. And so when we look at just kind of the component of hospital bills that goes to facility fees, we see really the similar story as before. And so there's a tremendous range in prices for hospital facility fees, with the range in prices being roughly a 2x across the country, ranging again from about 150% to about 325% just for facility fees. And so compared to the kind of overall variation, variation in facility fees really drive variation in hospital prices in the country. The second component that I mentioned earlier, the professional fee, both has relatively lower payments relative to Medicare. So as a percent of Medicare, the average hospital professional fee is around 150% of Medicare, compared to over 200% of Medicare for facility fees. And we also note just less variation overall. So with the exception of states like Wyoming, Minnesota, Wisconsin, and Alaska, there's really a much tighter range in prices for hospital professional fees than we see for hospital facility fees. And so again, if we look at kind of the components of hospital bills that are driving variation in prices, it's really driven by amounts that are captured by the hospital as a unit as a whole, rather than the amount that is going towards healthcare providers and the physicians. And so that is our kind of overall summary of provider prices. And so the kind of main takeaways that we find: tremendous range in prices that's not really, I think, correlated with the types of services or the factors that we want to be paying for, and is really in some senses driven by differences in market share. And so I think that's really important to have for kind of a high level look, but it doesn't necessarily answer the question of what is the price for a given hospital, and what do prices look like, and kind of payment components look like for a given provider. And so that's where we've actually been able to use a lot of this data in conjunction with one of our partners who actually originated this work, the Employers Forum in Indiana, and create this tool called Sage Transparency, where we have both individual provider prices and then also data points like payer mix, hospital profit margins, and quality metrics. And so the link here is dashboard.sagetransparency.com. If you can't remember the link, if you just Google Sage Transparency, it's literally the first thing that pops up. And so just to kind of go into that, what we find, so for example, for New York Presbyterian, you can see that there is at least in our data, as a percent of Medicare, New York Presbyterian charges 428%. But if you were to look at the price that would break even based on the payer mix and costs for other purveyors, it's about 139% of Medicare. And so there's a kind of a tremendous gap between what this individual hospital, New York Presbyterian, is charging and their break-even amount. And the delta between these two represents the margin for that provider. And then if we look at the other two bars, so we see that the same numbers for the state of New York, and then also for all other states. And so this is the part where I need audience participation. And so just to kind of highlight what this looks like, if someone wants to provide a state and then a hospital within that state, we can actually just kind of go over what prices look like for that provider.
You can start with New Hampshire, Chris. I'm cool with that.
New Hampshire, all right.
Oh, there we go. Somebody would like to see North Carolina and Atrium. I've seen New Hampshire 100 times, so.
Okay, so let's go to North Carolina. And so within the Atrium, is there a particular hospital within Atrium that we should look at?
Union.
Union. So within this, so we've got all the kind of facts, if you will. So we've got the Medicare provider number and their location, so we can be sure that this is the right hospital. We used data on payer mix, and so this is actually reported by hospitals to Medicare in their cost reports. And so we can see for this hospital, they're roughly 30% commercial payers, roughly 30% Medicare fee for service, and then about 15% Medicare Advantage, Medicaid, and charity care and uncompensated care or the remainder. Using data from Medicare on quality scores, they've got a 3-star rating for patient experience, and for quality, a 4-star rating. And if we look at a different measure of quality, which is constructed by Quantros, and is maybe less of an overall metric than the CMS star ratings, but actually goes into kind of more clinical outcomes. They actually have maybe not a great grade on overall surgical care, higher grade on medical care and overall care. But keep in mind, these are all below 60%, and so maybe not the best overall. If we look at prices, so we actually find that their total price is a little bit lower, or so there's 295%. But if we look at outpatient prices, we find that they're about 478% of Medicare. And so prices for overall care are about 300% Medicare, but for outpatient care in particular, almost 500% Medicare. That compares to the system, atrium system overall, almost the same for outpatient or for overall care, but quite a bit higher for outpatient care. So 478 versus 370, so almost a 100 percentage point difference. And then looking at benchmarks for the state of North Carolina, again, they're a little bit higher for overall care, but quite a bit higher for outpatient. And then compared to the rest of the country, quite a bit higher on both points. And then we also have, as I said earlier, the break-even point. And so if we were to look at just kind of the facility price compared to what they would report to break even. And so this hospital is a high Medicare and Medicaid hospital. And so it's important to account for those differences in payer mix. But we still see that they're charging on the facility side over 300% of Medicare, whereas we just kind of do the math on what they would need to break even based on their payer mix and their costs for those different payers, it'd be about 108% Medicare. And so that's a pretty large margin that's being built in. And again, that compares a little bit higher to hospitals in North Carolina and across other states. And if you want to look at individual prices for services, so we were also able to add in prices from the hospital machine readable files. This comes from Turquoise Health, which is a vendor that's been able to aggregate a lot of those posted prices. And so you can see prices for CT scans, cardiovascular care, ED visits, GI, and laparoscopic procedures as a percent of Medicare. And then going even more into categories, we've got a bunch of other categories if you want to look at individual prices for service buckets within the system. And so that's the kind of summary information that we have for hospitals. We also have hospitals by system. If you want to compare hospitals by state, we have that as well. And we recently added in hospital prices for ambulatory surgical centers. And so collectively we have about 4,000 hospitals and about 2,000 ASCs data. And so we designed this to be kind of as much data as we can add in for people who are trying to make decisions on payments or think about the markets to make those types of decisions, and just to be a source of truth for thinking about prices and add transparency to prices. And so I see a bunch of comments in the other hospitals. And so again, here's the link. And so it's possible to just totally go into any of those hospitals and do the same type of exercise. And so
Chris, are you seeing the question about the data sources? Or do you want me to, is it easier if I read those out to you?
Yeah, I see that question. So on that note, so that's a good question. So we have data from two main sources I mentioned earlier. So the self-funded plans and then also the APCDs. And so the APCDs are going to be a mix of individual and small group plans, but then also some large group self-funded plans, particularly from state employers. It'd be great if there was a national APCD that has everyone in the data set, but in the absence of that, we try to collect as much data as we can. A limitation with that is that there are going to be differences in the populations within the state. So in some states, we're maybe a little more disproportionate on the individual or exchange plans versus self-funded plans that we have. One thing I would note is that we don't have, we dropped all the Medicaid managed care, Medicare Advantage plans, and so we're restricted to the kind of true commercial population.
And Chris, when you have the data that's coming from a state APCD versus data that you've needed to go to the employers directly for a state, is that indicated somewhere? I think that's part of the question.
Oh, yeah, that is indicated, and so the states that we do actually have data from, and I have a slide on that that I can add in real quick, because we did highlight that in our report.
Right.
And so let me add that in right now, because that does lead to some difference. And so, okay, so so what I've highlighted here in red are the states where we have an APCD. And so in general, we do find that states that have an APCD do have lower prices. And so our percent of Medicare nationwide average was a little bit lower this year than or in round 4 than in round 3. And I think a big reason for that is that we added in APCDs for Arkansas and Washington, which tend to be, which are lower priced, especially in the APCD. And by virtue of having an APCD for 2 relatively large states, we just have a lot of volume that brings the weight down. I think it's a question of how much of the lower price in general that we see in APCDs is sort of correlation versus causation. And so it could be the case that if you have say a state like New Hampshire, which is an APCD for a while, that really just forms kind of a state policy and kind of provider and insurance market cohesiveness around making sure that prices are fair and efficient. On the other hand, Colorado, which is our APCD state with the highest prices, also has a great APCD that they use to inform policy, but we don't see the same story there. And it could also just be that say the Arkansas and Washington populations are just disproportionately individual or exchange market plans than in other states.
I could assume that some of our we probably don't need to go state by state here, but I would assume that some of our Colorado friends would probably weigh into why Colorado looks the way it does. But we won't.
Yeah.
We won't digress. I think there are a couple more questions that are methodological in nature, Chris, in the chat.
Okay.
So a question about a basket and mix. Did you see that?
I did. So yes, so that's so I see the basket mix question. So to be clear, so we're not. So there's maybe 2 ways to measure variation in prices. One is the basket and mix approach, and that is to say we're going to take the 100 most common procedures and look at variation prices across everyone just for those 100 procedures. A challenge there is that some providers may do more of one procedure versus another, or out of the 100 procedures, maybe some hospitals do 95, and so do you keep that hospital in or exclude it? What we use is a second approach. So we don't limit the number of procedures, but we use the Medicare case mix adjustment system to adjust across procedures. So for example, within Medicare, a procedure for say a chest pain patient showing up at the emergency department is paid quite a bit lower than a patient who receives a heart transplant. And so that the payment gap between the two is, I think the number is like 35.6x. And so we're using that variation in Medicare payment weights across different procedures to essentially weight our procedures. And so, for example, a hospital that has lots of say, joint replacement procedures, we're going to use the Medicare payment mix or case mix rather adjuster to adjust those procedures down so that we can compare them to, say, a hospital that does lots of MRI procedures. And then
Thanks,
I
Chris.
see the other question on the break-even price. I'm not actually sure on the capital assets question. The break-even price is actually developed by the National Academy for State Health Policy using data from Medicare cost reports. And so this is data that each hospital has to report to Medicare on their payer mix, the costs for providing care to those patients for each payer, and then also revenue from each payer. And so you kind of add the everything together and look at how much a hospital would have to charge commercial payers based on the costs of providing care and the revenues for providing care to non-commercial payers to break even, and acknowledging that the commercial payments probably gonna have to be higher to offset some underpayments from Medicare and Medicaid.
Thanks, Chris. And yeah, Chris, you have more that you wanted to go through?
So just, a couple of just wrap-up slides. So as we've been doing this work over the last couple of years, it's been really great just to see how the data has been used. And so how, at least I think of it, as that there's really a continuum. So some employers, purchasers, and policymakers are just kind of excited to have information about prices. Some have actually gone out and benchmarked prices. And then others have actually, I think, used the data pretty intensively and gone out and changed hospital networks. And so just to wrap up, the COVID pandemic has placed a lot of pressure on the healthcare system, but also on many employers. And so this is, I think, at a time when we actually need to have transparency on information on prices, because, frankly, there are lots of difficult decisions to be made about how to pay for healthcare. And it's really important to have, I think, accurate and reliable data on those to make those decisions. The huge variation that we highlight in hospital prices, in some sense, the glass half full view is that this is an opportunity for employers and purchasers to redesign benefits and either negotiate higher prices down or design programs to send patients to lower price but higher quality providers. And then finally, healthcare is so huge and complex, but the reality is that we pay for healthcare out of tax dollars, out of wages, and out of everything else that we could be using our resources on. And so I think it's really important for the people making those decisions, mainly employers, to actually have accurate data on prices and to make sure that they're actually useful. So thank you, and happy to answer any questions.
Thanks, Chris. There's a question in the chat about the transparency rule data that's required to be made available by hospitals, and one could probably say on the insurer side as well. And wondering about that, anything that you've done looking at those as potential data sources.
Yeah, that's a really good question. So we add that in to the turquoise data components that I highlighted in Sage. And so going back to this example, these prices here are all from Turquoise Health, which is a third-party company that essentially aggregates the data posted by hospitals as required by the CMS transparency regulations. And so that's the kind of endpoint for these data points. The advantage of, I think, these data points is that you can actually look at prices for individual procedures. The disadvantage is that I think it's been widely reported, not all hospitals are compliant, and the hospitals that are not complying are probably the higher price hospitals that maybe we care about price a little bit more.
Great. Thanks. And if you, and there's a sort of follow-up or subsequent question asking if you've seen what you've seen or around the differences between the prices that have been published by the payers and what you're seeing in the aggregated analytic work that you're doing.
Yeah, that's a good question. So that's something we're trying to work on now is triangulate a little bit. So the prices posted. So we have three prices. So prices that are posted by hospitals is kind of reporting this as our price. The second point we have is newer data, which is brand new, which is the equivalent posted by insurers, and so that lists the the insurer's record, if you will, on prices. And then the third point that we have is from claims, which we use, which is the amount of money that actually transacted hands. And we're in the process of basically trying to aggregate those three data points and triangulate and basically see, are there reporting differences or do things align pretty well? And so we're still a bit ways off from having things ready, but from our initial take, things actually do align pretty well. So I think it's maybe too expected that things aren't going to be 100% lined up, but things at least are directionally pretty similar.
Yeah. Folks, feel free to add your questions to the chat, or let us know if you want to unmute to ask a question verbally. So it will be interesting, Chris, that your next year is 2020 and 2021, right? With all the anomalies that are coming through in the sort of recovery from COVID, do you have any early predictions for what you think might be sort of different in the interpretation of the analysis as you look at the last 3 years in particular?
Yeah, so I think this will be really fun to look at. One of the things that we've consistently heard, and I'm not sure if other people in the call have also heard similar, is that the stressors of the pandemic, for better or worse, gave providers quite a bit of negotiation leverage. And so my guess is that if we look at 21, but especially 22, we actually might find an increase in prices for some providers, more so than we would have expected.
Yeah. Interesting. Okay. One other thing I wanted to just point out for folks, and I think this is still true, but Chris, you should definitely correct me if I'm wrong. I think for at least some of the states, the public use data file was sufficient for your uses for this study. Is that right?
From the state APCDs?
Yes. Sorry.
That's correct. Yeah. So I know, for sure, New Hampshire, the public use file was, and I think also for the state of Colorado. I mean, the states did vary in the data kind of collection process and the agreement process, and so each state kind of had their own process, but there certainly New Hampshire, we were able to use the public file.
Yeah. And thanks. I bring that up specifically because I know in some states in the conversations we had, the difficulty is getting through the data request process, which is obviously more difficult for limited use than it is for public use data files. And so for our state colleagues on the phone, if you're interested in being involved in this and having your state represented, just a note that you might not require the complexity of a limited use data file to get there. There's a comment about your thoughts around the federal funding around the pandemic and how that might impact either the analysis or the interpretation of the analysis as you go forward.
Yeah, that's a really good question from Leah. It probably won't impact too much on what we do on the prices end, because that's going to be purely the prices negotiated between providers and insurers. Where I think this actually may have quite a bit of difference is on the break-even tool, or break-even margin rather, reported by NASHB. And so I think, again, related to the capital expense comment earlier, if pandemic funding is counted as a a capital input from the hospital, then that's something that can just inflate a hospital's overall revenue stream and potentially bring down payer mix, or the break-even point rather. And so if that goes away, then maybe that's something that might influence break-even points rather.
Great. Yeah, a lot remains to be seen in that for sure. Any other questions on the chat? If while we're waiting to see if any additional questions come up, Chris, do you want to maybe talk to the folks on the line about how they could get involved if they'd like to?
Yeah, so honestly, the easiest thing is just to send me an email, and happy to put that in the chat. And then we have a team that can help with the data use process and the data transfer process. And just one point to note, participating is free. So as I mentioned earlier, our study is funded by the Robert Wood Johnson Foundation, and so there's no cost to participate.
Great.
With the caveat that, I mean, as I did also mention, for the kind of subset on individual providers, or individual payers or purchasers, we do charge a little bit for that, just to cover our programmer time.
Yeah, well, yeah, got it. I think one of the general questions is, in the I'm sure in the conversations that you've had and in the relationships that we've been leveraging and building really with the employer community with organizations like the Indiana Employers Forum, or the Employer Forum of Indiana, that started this work. I think this, from a state APCD standpoint, building their relationship on the employer side is a really big part of what the states are seeking to do. And this seems like a way to at least demonstrate the value of contributing data to state APCDs that are integrated into this. Do you have any thoughts about kind of connecting those dots between the work that you're doing, the contribution of a state APCD, and for employers that are finding this valuable but maybe not necessarily being active participants in the state APCDs? Any thoughts you have about ways to bring that conversation forward?
Yeah, I think the reality is that in a state with a functional APCD, and I really point to New Hampshire, Colorado as the leading examples of how the APCD has been able to been not just kind of a thing that's sits there, but actually is used to inform policy. I think that there's a tremendous benefit for employers in just benefiting from those policy discussions, but then also being able to add it to their prices. And so, for example, in the state of Indiana, that's a state where there has not been a APCD, but there's been a tremendous amount of interest on behalf of employers to have discussions around provider prices and to have policies around provider prices. And they recognize that they can't have that type of informed policy without accurate and transparent data. And so there's been a pretty large state level push to form an APCD within the state of Indiana, but then also kind of a accompanying effort from employers to contribute data to the potential APCD. Just because I think that they recognize the symbiotic relationship between having an APCD and the improved policies that can come out of that information.
Yeah, great. Thanks, Chris. All right. Any other questions, comments for folks on the line? All right, if not, I will hand it back over to Norm and Charles and take this opportunity again to thank you, Chris, for taking the time to talk with us today. Super interesting work. You know, I've been following this journey, I think, since RAND 1.0. So I'm really excited to see what happens in 5.0.
Yeah, well, thank you.
Yeah,
Great,
thank you both, Chris and Joe, for leading off with this. Our next Hot Topic webinar will be coming up again in a couple of months. We don't have the topic ready to announce yet today, but we will announce that in our upcoming newsletters. And hopefully you can all join us again for that. And we will see you there. Also, if you haven't already, please mark on your calendars August 14th to 16th, our in-person networking event in Boston. We're so excited for that to happen. It's going to be a great time, lots of fun, good food, good city, good content, good conversation. So please mark that on your calendars. The registration will probably open in the early part of May. So watch for an announcement about open registration. With that, we're going to go ahead and conclude, and we will see you all again soon.